Okay, let's unpack this deep dive. We've got quite a stack of sources here, really getting into glucagon-like peptide 1 agonists, GLP-1s,
Hmm.
and specifically their role in managing type 2 diabetes right here in the UK.
Yeah, the focus is definitely UK-centric this time.
Absolutely. And this isn't just skimming the surface. We're drawing directly from NHS trusts like Guy's and St. Thomas's, professional guidelines, the BLMK APC stuff, which aligns with NICE, and also patient-focused info from Diabetes UK.
Which is great because you get that blend, don't you?
Yeah.
The clinical guidelines side by side with the sort of practical on-the-ground perspective, including, recent headaches like supply problems.
Exactly. It gives a much richer picture. So our mission here is to take all these different pieces and, well, pull out the really key information for you.
Yeah, to make sense of it all.
We want you to come away with a clear understanding of GLP-1 agonists, why they're important in diabetes care, what patients and healthcare professionals need to know, and what's been happening recently with getting hold of them.
Definitely. And just a quick but, really important point before we dive in properly.
Go ahead.
This deep dive is purely for educational purposes. It reflects the guidelines and best practice based on these sources at the time we're recording.
All right, things can change.
Exactly. So you should always check the latest local and national guidance. And if you're a healthcare professional, always use your clinical judgment when applying any of this information.
Essential disclaimer. Okay, let's get into the science bit then. How do these GLP-1 agonists actually work? What are they doing inside the body?
Well, think of them as mimics, essentially. They're medicines designed to copy a natural hormone your body produces, called GLP-1.
Okay, a hormone from the stomach.
Yeah, released when you eat.
Hmm.
And it sends signals around. These drugs basically copy those
So
signals.
they're amplifying a natural process.
In a way, yes.
Mm.
And the sources highlight a few key things they do. First, they help your pancreas make more insulin, but crucially, only when your blood sugar is rising, like after you've eaten.
Ah, so it's smart, not just pumping out insulin all the time.
Precisely.
Yeah.
Conditional release. They also signal to your liver to cut back on the amount of sugar it releases into your bloodstream.
Which can be excessive in type 2 diabetes.
Exactly,
Yeah.
especially between meals or overnight.
Yeah.
So GLP-1 agonists help rein that in.
Okay, smarter insulin, less liver sugar. What else?
They also slow down how quickly food leaves your stomach gastric emptying,
Oh, okay.
which means the sugar from your food gets absorbed more slowly, leading to a more gradual rise in blood sugar levels.
Makes sense.
And kind of a side effect of all this, which is quite significant for many people, is that they can reduce your appetite.
Right, which explains the link with weight loss we sometimes hear about, even if that's not the primary diabetes license focus.
Hmm.
So, knowing how they work, where do the UK guidelines like NICE say they fit in? Are they a first line thing?
No, not typically first line. The sources, aligning with NICE guidance, that's NG28, position them as an option for adults whose type 2 diabetes isn't controlled well enough just with diet and exercise. They usually come into play when other oral medicines haven't quite done the job. Specifically, the guidelines mention considering them when triple therapy that's usually metformin plus two other types of diabetes tablets isn't working well enough, or maybe the person can't tolerate those drugs or they shouldn't take them for some reason.
So, a step after trying a few oral options generally, and the guidelines are quite specific about who gets considered, aren't they? It's not just about blood sugar levels.
That's a really key point from the guidelines, yes. It's not just the HbA1c number. NICE NG28 talks about considering them for adults with a body mass index, a BMI, of 35 or higher.
Okay, 35.
And, importantly, adjustments are made for people from minority ethnic groups who might be at risk at a lower BMI. And this is crucial. These individuals should also have specific psychological issues or other medical problems linked to their obesity.
So, high BMI plus something else related to the weight.
Yes, that's one route. Or the alternative is for people with a BMI below 35. They might be considered if starting insulin would cause major problems for their job, perhaps shift work or driving, or if losing weight itself would significantly help other major health complications they have linked to obesity.
Right. So it's quite targeted, not just about glucose control, but that wider metabolic picture, especially weight.
Exactly. The sources really emphasize that targeting.
And who typically starts these? Can your GP prescribe them straight off?
Well, the sources say initiation can be done by specialist teams and hospitals, diabetes clinics,
Hmm.
or by healthcare professionals in general practice, like GPs or practice nurses. But And this is important. They need to have the right expertise and experience. And it must always align with the NICE guidance and this specific license for that drug.
Expertise is key then. Okay, let's get practical. How are these medicines actually taken? We think of injections, mostly.
Yeah, many of them are injections, given just under the skin, subcutaneous injections.
Right. And where do you typically inject?
The common spots mentioned are the front of your thighs, your tummy area, the abdomen, or your upper arms. Your nurse or doctor will show you the best place and exactly how to do it.
But you mentioned there's an oral one now.
Yes, that's right. There's a tablet form of semaglutide, which goes by the brand name Rybelsus.
And I gather taking that one needs special attention.
It really does. This comes across very clearly in the sources because absorbing these peptide drugs orally is tricky. You have to take one tablet once a day, first thing when you wake up, and crucially, on a completely empty stomach.
Right.
You swallow it with just a tiny sip of water. They specify no more than half a glass, about 120 milliliters.
A tiny sip.
And here's the big one. You must wait at least 30 minutes after taking the tablet before you eat anything, drink anything else, or take any other medication.
30 minutes minimum before anything else passes your lips. Wow.
Yeah. The sources stress that food, or even drinking more water too soon, can really mess with absorption and make the drug much less effective.
That's a significant commitment for taking a tablet. Really highlights the challenge of getting these drugs into the system orally.
It does. And for any form, injection, or tablet, your healthcare professional works out the dose, how it might increase over time, the timing. And they often provide a patient booklet, the sources mention, to help you keep track of instructions, doses, and any changes to your other meds.
Okay. So once someone's on the treatment, how is it monitored? What are the checks?
Monitoring is vital, both for seeing if it's working, improving diabetes control, and for checking for side effects.
Makes sense.
The standard things measured are your HbA1c, that gives the average blood sugar picture over the last few months. Your weight is also tracked. And they'll do a blood test to check your kidney function, usually reported as eGFR.
Okay, HbA1c, weight, kidneys, how often are these checks done?
There's a recommended schedule. Usually after about a month, there's a check-in, mostly about how you're finding it. Are you taking it correctly? Any side effects bothering you? Then at 3 months, they'll likely check HbA1c, weight gain compliance, side effects. But the really critical check, according to the guidelines, is at 6 months.
6 months. Why is that one so important?
Because that's when they properly assess effectiveness. They compare your HbA1c and weight at 6 months to what they were before you started the medicine.
Ah, the baseline comparison. So is that the point where they decide if you stay on it?
Pretty much, yes. The NICE BLMK guidance is very specific here. Treatment with a GLP-1 agonist should only be continued beyond 6 months if you've had what they call a beneficial metabolic response.
And what does that mean specifically?
It means meeting 2 criteria. You need both a reduction in your HbA1c of at least 11 millimole, that's equivalent to 1.0% NDD. You need to have lost at least 3% of your initial body weight.
Wow, both targets have to be met, not just one.
Both. The sources imply this shows the drug is having that desired broader impact on both glucose and weight, justifying its continued use and, frankly, its cost. If you only hit one target, the guidelines suggest it might not be providing enough overall benefit to continue.
That's a high bar, but it makes sense clinically. What about after 6 months?
There's usually another review around 12 months. And at that point, if the good response you saw at 6 months hasn't been maintained, maybe HbA1c has crept up or weight loss stalled, then they'd consider stopping the treatment. It acknowledges that type 2 diabetes can't progress, but continuation relies on ongoing benefit.
Right. Okay, let's shift to side effects. What are the common things people might experience?
Well, the patient leaflet always has the full list, and you're unlikely to get everything, of course, but the most common ones mentioned in the sources are definitely tummy-related.
Like feeling sick.
Yeah, nausea is quite common, especially at the start. Diarrhea can happen too, or sometimes stomach pains or constipation. Some people find their appetite reduces quite a bit or get headaches. And with the injections, you might get a skin reaction where you inject.
Do those usually get better? The nausea and diarrhea?
Often, yes. The sources suggest they tend to improve or go away completely as your body gets used to the medication over time.
That's reassuring. But are there any really serious side effects, any red flags people absolutely need to watch out for?
Yes, there's one very critical warning sign highlighted across the sources.
Okay.
If you experience severe stomach pain that doesn't go away and maybe feels like it's going through to your back, sometimes with vomiting, sometimes without you You must stop taking the medicine immediately and get medical help, like straight away.
Why? What could that be?
It could be a sign of pancreatitis, which is inflammation of the pancreas. It's serious. And if pancreatitis is confirmed, you should never restart that medicine.
That is a crucial warning. Severe, lasting stomach pain, maybe radiating to the backstop and seek help.
Got it. Anything else to consider before starting?
Yes. The sources mention the importance of having an up-to-date diabetic eye check before you start.
Why is that? Well, particularly if you already have some diabetic retinopathy damage to the eye's blood vessels, and especially if you're also taking insulin, there's a note of caution about a potential, though complex, risk of things worsening initially. So definitely tell your doctor or nurse about any eye issues you have.
Okay, good point. Now, what about people who definitely shouldn't take these, or situations needing extra care? Contraindications.
Yes, the BLMK guidance table is really useful here. They are absolutely contraindicated, a definite no-go if you have type 1 diabetes or if you're in diabetic ketoacidosis, DKA.
Right.
Also during pregnancy or while breastfeeding. And for women who could become pregnant, effective contraception is recommended. You should stop the treatment before trying to conceive. Semaglutide, because it hangs around in the body for a long time, needs to be stopped at least 2 months before planning pregnancy.
2 months for semaglutide, okay. What about kidney or liver problems?
Yeah, there are cautions. They're generally not recommended in end-stage kidney disease for some types like semaglutide and liraglutide. Or if your kidney function, that eGFR measure, is very low, below 15 for dulaglutide, for example. With severe liver problems, liraglutide isn't recommended, and there's caution with semaglutide due to lack of data.
Any other condition?
Caution is advised if you have severe gut problems already, like gastroparesis, where your stomach empties really slowly, because these drugs also slow emptying. We mentioned retinopathy with insulin. Liraglutide needs caution with pre-existing thyroid disease. And if you take semaglutide and levothyroxine for thyroid issues, they might need to monitor your thyroid levels more closely. And always remember the risk of hypos, low blood sugar, especially when combined with certain other diabetes meds.
That guidance is quite detailed. How do GLP-1s play with other diabetes drugs? Can you mix and match?
There are definite rules. The big one is you should not usually combine them with DPP-4 inhibitors drugs like sitagliptin or alogliptin.
Why?
Because they work on a very similar pathway in the body, involving incretin hormones. So using both together isn't thought to add much benefit and is considered a waste of resources according to the sources.
Okay, avoid DPP-4s. What can they be combined with?
They can be used alongside metformin. They can be used with thiazolidinediones like pioglitazone. Combination with SGLT2 inhibitors, the ones that make you pee out sugar, like dapagliflozin, is acceptable, although the sources note this can be a costly combination.
Right.
And if you combine them with a sulfonylurea like gliclazide, you need to be careful. The guidance suggests potentially reducing the sulfonylurea dose because the risk of hypos increases significantly.
And what about adding them to insulin? That sounds complex.
It is, and it requires specialist oversight. Combining a GLP-1 agonist with insulin should only happen with advice and support from a hospital diabetes team or a specialist nurse team. There are specific criteria they consider, things like how long you've had diabetes, how much insulin you're on, your remaining pancreas function, whether you're okay with it. They might switch you to a human insulin type if possible, and they'll definitely review your background insulin dose carefully to cut the hypo risk. And again, there are strict rules for continuing that combo based on HbA1c and weight at 6 and 12 months.
It really hammers home that if you have any concerns, tricky situations, interactions...
Absolutely. Talk to your healthcare team. The sources stress seeking advice for any tolerability issues, complications. If you're planning pregnancy or become pregnant, stop immediately and get urgent advice. Or if you're thinking about higher doses, off-guideline use, or drug interactions.
Now, we have to talk about something that's been a huge issue recently, the supply problems with these drugs in the UK. What do the sources say?
Yeah, this was, and to some extent still is, a major topic. The sources, especially Diabetes UK's FAQs, clearly state there were intermittent supplies and shortages of GLP-1s, and this had really serious consequences for a lot of people with type 2 diabetes.
What caused it? Was it a manufacturing problem?
Primarily, it was down to a massive global surge in demand, and a significant part of that surge was driven by off-label prescribing, particularly for weight loss, which just completely outstripped the manufacturer's ability to produce enough.
So demand for weight loss use squeezed out the supply for the licensed diabetes use.
That's essentially what happened, yes.
Yeah.
During the worst of it, around summer 2023 onwards, stocks had to be very carefully managed, mainly reserved just for people already established on the treatment.
Which meant?
It meant that many people who met the 9Z's criteria for type 2 diabetes and could have really benefited from starting a GLP-1 agonist simply couldn't. They couldn't get a new prescription started.
That sounds incredibly frustrating. Has it got better now? Is it resolved?
According to the Diabetes UK update from February 2025, yes.
Hmm.
They reported that stocks were resupplied towards the end of December 2024, and the issue was considered resolved as of that February update.
Did the shortage force any changes in how things were prescribed?
Oh, definitely. It shook things up. There was a national patient safety alert in January 2024 that actually allowed doctors to start new patients, specifically on Ribelsis, the oral semaglutide tablet, because there was better stock of that compared to the injectables.
Ah, interesting. So the tablet became an option to start people on.
Yes.
Hmm.
Also, Bieta, which was one of the older injectables, was discontinued around March 2024, and patients were switched, often to Ribelsis. And another factor was Mounjaro tirzepatide, which is a newer drug acting on both GLP-1 and another hormone called GIP. Got approved for type 2 diabetes during 2024 and became another option people could be started on or switched to if other GLP-1s weren't available.
So Mounjaro offered another route. What about Wegovy? That's the semaglutide brand specifically for weight loss, isn't it?
Yes, and the sources are clear. Wegovy's availability remains very restricted. It's only through specialist NHS weight management services or prescribed privately by registered professionals, meeting the strict NICE-E criteria for weight loss, and it has to come with diet and exercise support. It wasn't and isn't just available on a standard prescription during or after the shortage for either diabetes or weight loss generally.
So what's the practical advice for listeners now, based on the sources?
Okay, so if you were already on a GLP-1 and weren't really affected, you should hopefully be getting your supplies as normal now. If you do run into problems getting it, contact your GP or diabetes team straight away.
Right.
The sources strongly advise not to ask for bigger supplies than usual. Don't try to stockpile, as that just puts pressure elsewhere in the system.
Okay, good point.
If you were someone who was told you might start one but couldn't because of the shortage, now is the time to bring it up again at your next review, as initiation might be possible. And similarly, if you had to stop taking it due to the shortage, discuss restarting with your team if it's still appropriate and likely to benefit you.
What about taking it, say, only when you can get it, using it sporadically?
No, the sources strongly warn against doing that. Taking it intermittently is risky. It can increase side effects when you do take it, and more importantly, it leads to unstable blood sugar levels.
Which is dangerous.
Yes, unstable blood sugar increases the risk of complications. You might get symptoms of high blood sugar like extreme tiredness, thirst, needing the loo all the time, and in the worst case, it could even lead to DKA, that serious emergency state. Consistency is really important. Either take it regularly as prescribed or stop completely under medical guidance. Don't dip in and out.
That's a very clear message. Consistency is key. Now, while these drugs are clearly powerful, the sources constantly remind us they're meant to be used alongside lifestyle changes, right?
Absolutely. They are an adjunct, a helper, to the cornerstones of managing type 2 diabetes, which are diet and exercise.
So what sort of diet advice did the sources give? Anything specific?
Yes, the guys in St. Thomas's source has some really practical do's and don'ts.
Okay, give us the highlights.
For the do's, aim for small, regular meals. Choose high-fiber, starchy foods, think whole grain bread, pasta, oats, beans. Get your 5 a day of fruit and veg in, maybe veg or salad with every meal. Spread fruit through the day. Use healthier fats like olive or rapeseed oil, but sparingly. Go for leaner meats and fewer fried or fatty foods generally. Use artificial sweeteners if you need them instead of sugar. And switch sugary drinks for diet or no added sugar versions.
Sounds sensible. And the don'ts?
Don't have huge portions of carbs, bulk up with veg instead. Lemon fruit juice, maybe just a small glass, about 125 milliliters daily. Cut down on saturated fats, things like butter, pastries, fatty cheese, cakes. Avoid obviously sugary foods and drinks as much as possible. Go easy on the salt. Use herbs and spices for flavor. And keep alcohol within limits, no more than 14 units a week, spread out with alcohol-free days.
Very clear guidance. Didn't they also mention a visual aid for meals?
Yes, the dinner plate model. It's a simple idea for portion control, especially if you're aiming for weight loss. Imagine your plate. Fill half of it with vegetables or salad, then fill 1/4 with protein meat, fish, eggs, beans, lentils. And the last quarter with starchy carbohydrates, potatoes, rice, pasta, bread.
Half veg, quarter protein, quarter carb. Easy to visualize.
Yeah, and the source gives examples of healthier swaps too, like high-fiber cereal instead of sugary ones, or grilling food instead of frying.
Beyond your own diet and exercise efforts, what other support is mentioned?
The sources point towards other helpful options, things like referring you to local or maybe digital weight management programs. Diabetes remission programs might be an option for some, and structured diabetes education courses, again, often available locally or online, are really valuable. Plus, that patient booklet we mentioned earlier is designed as a tool to use with your healthcare team to track everything: meds, side effects, measurements, targets, lifestyle goals.
Right, there's a whole package of care. So this has been a really thorough look drawing on those UK sources. Just to quickly recap, GLP-1 agonists are clearly powerful tools for type 2 diabetes.
Working in several different ways to tackle blood sugar and often weight, but their use is guided by specific UK criteria, like those from NICE, and requires really careful monitoring and awareness of side effects and contraindications.
And that recent context of supply issues was very real, impacting access significantly, although the sources suggest that's now resolved. But it did lead to changes in prescribing, bringing options like oral semaglutide and Mounjaro more into focus.
Yeah, and hopefully understanding all these details pulled straight from these reliable UK sources helps empower you to have better, more informed discussions with your own doctor or nurse about whether these treatments are suitable for you and how they fit into your overall diabetes plan.
Definitely. And looking ahead, as we see these newer agents like Mounjaro, which target both GLP-1 and GIP receptors, it makes you wonder, doesn't it? How might this kind of dual hormone approach further change the landscape for managing both diabetes and weight? And what new questions or complexities might that raise for everyone involved?